Hi, my name is Samantha Theisen. I go by Sam. I'm a DNP student here at Maryville University, and I'm here to talk to you today about my DNP project, which is titled Care Folders to Improve Blood Pressure Monitoring Amongst Chronic Kidney Disease Patients. Before we begin, I may utilize a few acronyms during this presentation, so I just wanted to make it very clear to all of those listening what those stand for. So sometimes I'll be using CKD, which refers to chronic kidney disease, and sometimes I'll be using BP, which refers to blood pressure. For this project, I needed a committee to help me through this process. So I would first off like to thank Dr. Boniface Stegman, who was my chair member, Dr. Jennifer Brunsworth, who was the second reader for my project, and then Dr. Carl Dean, who was my community member, for their help throughout this journey. To begin, I want to introduce you with what inspired my project. As many of you know, chronic kidney disease refers to a multitude of conditions that can cause your kidneys not to function correctly. The prevalence of CKD is continuously growing, and this makes it critical for healthcare providers to need to know how to treat patients with chronic kidney disease. One factor that can contribute to worsening chronic kidney disease is hypertension, which is high blood pressure. To accurately treat CKD patients, healthcare providers need up-to-date blood pressure readings in order to manage the patient's blood pressure accurately. In a study that I found by Zhang et al., out of the 1,750 CKD participants who had a history of hypertension, they found that only 67% were actually controlling their blood pressure, which shows there's a significant problem caused by a lack of adequate blood pressure management. There was further evidence to support that when patients monitor their blood pressure more frequently, the rate of uncontrolled hypertension decreases. Increasing their monitoring of patients' blood pressure with hypertension to once a week has been shown to reduce a population with uncontrolled hypertension from 39% to 27%, which although that is a small number, it is still showing an improvement. And it also shows the importance of at-home blood pressure monitoring for patients with chronic kidney disease and hypertension. I used to work as a nephrology nurse, which is what sparked my interest in this topic. The goal as a healthcare provider is to improve patient outcomes and patient care. So over the last 3 years, I've gained expertise in the CKD patient population, and I've noticed that there is a lack of at-home blood pressure readings reported from the patients to their nephrology team, which is very alarming, especially when it's well known that managing a patient with CKD's blood pressure could potentially help prevent the patient from needing dialysis. And in all reality, can also prevent a person to even getting CKD. So that shows that there needs to be a change to improve the care for CKD patients with hypertension. As you can see from this information, it is clear that there is significant need to help with this problem. The purpose of my scholarly project was to improve patient care, number one, by increasing at-home blood pressure readings amongst chronic kidney disease patients with hypertension. The goal was to have more patients provide at-home reading documented and then give those to their nephrology team to have in their medical records. So I was very hopeful that the results I would get from this investigation would show that the implementation of this procedure would increase the percentage of chronic kidney disease patients who monitor their blood pressure at home. My very specific aims I had included improving patient understanding of the connection between hypertension and chronic kidney disease, and giving clear instructions to the patients on how to monitor their blood pressure at home, and provide better medication management, which we can get if we have more accurate blood pressure readings. Another aim was to provide as many patients as possible with recording sheets to monitor their blood pressure at home, because giving them sheets sometimes motivates them to actually record their blood pressures, where if they don't have anything to record on, they might not. And I was hopeful these aims would lead to good results for this project and increasing the number of patients who monitor their blood pressure at home. So in order to find the information I needed to back this project, I did an integrated review of the literature. From the literature review, it was clear there was a change that needed to be made to increase the number of patients who monitor their blood pressure at home. I looked at 10 articles, and from those 10 articles, I found three main themes: white coat syndrome, noncompliance, and education. These themes were relevant to this scholarly project specifically, as white coat syndrome can affect a patient's treatment plan for hypertension. And if patients are non-compliant with their Claripan, no improvement can be made. Education, again, relates to this project because education is incorporated into this project to help patients understand the importance of at-home blood pressure readings. These themes help to support the need for a practice change and help to support the backing of this project. A little bit more about these themes. White coat syndrome refers to when a patient comes into the office and they have their blood pressure reading, and their blood pressure is reading higher than what they would be if they were at home. Sometimes people get nervous when they're with doctors, and doctors are known to wear white coats, so that's why it's called a white coat syndrome. It's routine to check patients' blood pressures during a nephrology clinic appointment, and that obtained blood pressure reading can be helpful to providers to give them an insight into the patient's blood pressure status. However, since there's such high variability in blood pressure values in routine office settings due to the white coat syndrome, it's better to have some outside readings so we can see the norm for that patient. For non-compliance, it's a term that probably many of you have heard. It just refers to patients not being compliant, not following through on the recommendations that are provided to them. Originally, when I started doing my research, I was using the word compliance because I was trying to be optimistic and trying to find research about patients being compliant, but I was finding more evidence on the non-compliance. What I found was that patient engagement in blood pressure control was low. They weren't feeling like they knew what they were doing, and there was a strong correspondence between patient perception and understanding and their participation in the compliance with the treatment plans. In one study by Zua et al., only 25.7% of that population with hypertension was completing recommended at-home blood pressure monitoring, which shows a lack of compliance with the patients completing what was asked of them. Which brings you to the education. So with non-compliance, a lot of it is due to the lack of education and the need for education. In a study by Milani et al., they suggested that poor health outcomes can occur when patients are provided limited resources and time for education, which stresses the fact that we need to take the time to really sit with our patients, make sure they understand what's going on with their health, and understand the recommendations that we are making for them. For my project, I used the contemporary change theory, which is John Coder's theory. It has 8 steps. It's a theoretical framework that incorporates building a solid team with all personnel essential to the change. Since I was working on a transformational change for the organization, which is a small nephrology practice that I was working with, I figured that this contemporary change theory was a good one to follow for this project and to be successful. So a little bit about the 8 steps. The first one is talking about altering others to the necessity of the change. So that's just alerting others and letting them know that if there's a problem, it requires people to get out of their comfort zone and explore a new way of doing things in order for them to be accepting of this change. It's really vital to inform the team why the change is needed and stress the urgency in order for them to be accepting of this change in process so that they would be willing to help with this change. The second step requires developing a solid team. So for this Scholargy project, the team included the clinical support system specialist and nephrologist. It also worked with the nurse manager, the clinic manager, the CEO, and of course all the staff as well, because they were going to be involved with passing out the care folders to patients. A third stage for Coder's model was narrowing the vision for the project. Narrowing the vision helps you kind of focus in on what you really want to do and the goal you want to have. And with that, then you can figure out the goal, which to share with the employees, which is the fourth stage of Coder's framework, which also encourages you to share the vision with the staff. The fifth portion of Coder's framework focuses more, again, to the staff. So this is why I really like this framework, is because it really focuses on getting everyone involved, which is necessary in order to be successful in this type of project. So the fifth step was redirecting the staff back on the focus and educating them again before we rolled out the new procedure. The sixth step was making small goals. So originally the short-term goal was to complete distribution of the care folders, and we saw the first real sign that the progress had happened when we saw that all of the folders we made were gone, and then we started to see at-home blood pressure readings coming in from patients. The seventh stage of Cotter's theory is it's essential to ensure the staff continue to be motivated. So while the staff might be motivated at first when you change something because they know about why it needs to happen, sometimes that motivation can drift off. So for this project, I would do weekly updates with the staff in order to keep them motivated, to share the progress and give words of encouragement. And then the final stage of this framework focused on the culture. You really need a culture that's open to change. The nephrology clinic that I worked with, this was going a lot during the COVID times, and so there was a lot of staffing turnover, and there was just a lot of changes that they were trying to do to improve care overall for patients. So there was that culture for change, but in order to have it, I needed to give praise often for the project and encourage the staff so they could feel optimistic about what was going on. For my project, it was a quality improvement project, and I used the framework of Plan, Do, Study, Act. The goal of my project was to better patient care. That's ultimately what I want to do as a nurse practitioner, as a healthcare provider. I targeted improving the quality of care and bettering patient care because of better quality. So once I planned this project, I implemented the procedure. The method for data collection was to gather quantitative data that evaluated groups of CKD patients with hypertension. The base data was gathered to determine how many patients currently have at-home pressure readings that they reported to the nephrology team. So that would be the pre-intervention group. And then there was and so I would do that by reviewing their medical records to determine if there were at-home blood pressure readings recorded. Following this, the procedure was implemented. The data was reassessed, which was reassessed after we gave them the care folders, and we just wanted to see how many patients now had at-home blood pressure readings in their chart. This was all used during using an electronic health record system. A lot of it was done using manual reviewing, and some systems reporting was done, but it was a little tricky just because I wasn't 100% sure on the different reporting things I needed to use. So this project, as I mentioned earlier, was conducted at a privately owned nephrology clinic in the Midwest United States. We used the electronic health records from patients with chronic kidney disease and hypertension, and we had a set inclusion and exclusion criteria in order to get the 159 patients we ended up with. I will discuss those inclusion and exclusion criteria later. Before I implemented this project, there was not really a set protocol at the nephrology clinic to encourage at-home blood pressure monitoring. To make a consistent quality improvement protocol for all patient appointments, I had to work closely with the staff to implement this new procedure, as I discussed with that framework model. I used a retrospective chart review. So everything was looking back through the patient's charts, and I didn't actually communicate with the patients face-to-face at all. There wasn't any participation engagement, and then also no patient identifiers were taken from the EHR. EHR means electronic health record. All the patient identifiers were removed from the record, and I did all this reviewing until I could get 159 patients who met the criteria that I needed. I wanted to include this figure to show you a little timeline of my project. Just to sum it up, as you can see, the main steps including the planning phase, the IRB approval. So that is, for me, I only had to get IRB approval through Maryville. The nephrology practice did not have an IRB, but I did get approval from their board of directors and from their CEO. The next step was education. So that was educating the staff, and then implementation of the care folders. That started on May 9th. And then after that, I needed to get the results. So I did my retrospective chart review, did my data analysis, and that went around August 1st through February 1st. So my original aim for sample size was 155, and thankfully I was able to get 159 patients that met the following criteria. So to be included, the patient must be 18 years or older, have documented in their EHR that the patient went to an appointment in the clinic from May 9th of 2022 through December 31st of 2022. They had to be enrolled in the registries for chronic kidney disease and hypertension, and they needed to have in their chart that this procedural intervention was implemented. While they needed to meet all of that, they also needed to be filtered for exclusion criteria. So patients were excluded if they were 90 years or older, or if they were younger than 18, if they completed a visit via telehealth, if they had a contradiction of dementia, just because that limits the amount that the patient's able to do themselves, and if they had not completed a follow-up visit within the 6 months of the intervention. What I got, the sample consisted of 11.3% of patients who documented their at-home blood pressure records in the AHR prior to the intervention, so that's about 18 patients, and then after the intervention I had 40 patients, so 25.2%, who had blood pressure readings in their chart after. A quantitative study with nominal data was used. The estimated sample size was 159, which actually ended up, 155, and then the actual size was 159. I ended up running a z-test for the difference of two proportions. I had the independent variables of pre-procedure and post-procedure, which I coded as 1 or 0 respectively. The dependent variable was yes, so yes, the patient has a blood pressure log in the chart, or no, it does not have a blood pressure log in the chart. These were recorded as 1 or 0 again. I used a statistician through Maryville University, and then we used the statistical program of SPSS to analyze the data. I worked together with this statistician because I honestly just am not a great statistician on my own. The z-test for the difference of two proportions indicated that there was statistically significant data to show an improvement in the number of patients with at-home blood pressure readings pre-intervention compared to post-intervention. The pre-intervention group proportions of patients who had at-home blood pressure readings was 0.113, so 18 patients as I mentioned earlier, while the post-intervention group proportion of patients with at-home blood pressure readings in their chart grew to 0.252, which equaled 40 patients. The p-value I got from this test was 0.007, which was less than the significance level of 0.05, which indicated that there was statistically significant data to support the implementation of the care folders protocol. The next few slides include figures and tables to display the results. Graphs and tables are utilized to help visually explain the relationship between the data and to provide a clear interpretation of the results. So I wanted to make sure you had these for better understanding. This first table shows the statistical results from the z-test of the difference of two proportions. So these are the results that I got from the SPSS and shows all the stats that we need to know for this project. This next one is a bar graph which shows the number of patients with at-home blood pressure readings documented in their EHR chart before and after intervention, so that one's nice so you can compare the two results. With any test, it's important to note that limitations can happen, and with this doctoral project, there were limitations. So it is possible that there was response bias that impacted the results. The study completely relied on patients' honesty in reporting their blood pressure at home. It is possible that patients provided inaccurate or false readings in order to please their nephrology team, or if they didn't want to have any changes in their care, they might have just provided different blood pressure readings so they wouldn't have any medication changes. It's also very limited in the fact that it focuses on a specific population. While the population of patients with CKD and hypertension is quite large worldwide, many patients with hypertension do not necessarily have chronic kidney disease, and a lot of patients with chronic kidney disease don't necessarily have hypertension. This could classify the project as having poor generalizability. With the results of this study should be sustained, there isn't enough evidence to state that intervention would have long-term effects on a patient's motivation to monitor their blood pressure. There just wasn't enough time to look at this over a really long period, which these limitations can weaken the study's results or one belief that the intervention is worth implementing. This doctoral project showed statistically significant difference between the pre-intervention and the post-intervention results. That indicates that the procedural intervention provided to patients with chronic kidney disease and hypertension proved effective, increasing the number of patients who monitor their blood pressure at home and reported back to the nephrology team. Increased blood pressure readings improve the nephrology team's ability to improve blood pressure control. The results of this project provided implications for practice and for future research. The results show statistically significant data, as I stated, but it's only been completed one time, so it's recommended that a repeat study be conducted to confirm the results. Additionally, future researchers would benefit from having a longer period of observation, which would allow the researchers to see if the intervention was sustainable. It would also be nice to have a larger sample size to increase the strength of the results. Healthcare policies are in place to provide safe care, cost-effective care, and improved overall healthcare to patients. This project was deemed to be no risk to the patients. There were no perceived damages that could happen. So because of this, there are implications that the intervention could be worked into regular policies, procedures, safely and specifically at nephrology clinics. And the cost was really low to do. We really had to just pay for printing and folders, and that really didn't end up costing too much. So in conclusion, the results of the scholarly project found that the implementation of a procedure introducing care folders into a patient's care plan can increase the number of patients who monitor their blood pressure at home and report it back to their nephrology team. These results back the recommendations that the intervention would be beneficial for entrance into practice. It's recommended, though, that further research be done to confirm the results and to determine sustainability of the intervention. This intervention will impact practice as it will provide more accurate data to the healthcare team, specifically at nephrology clinics, to allow them to provide safer and more effective care for the patients. And now I would like to open up for some time for some questions. And then I wanted to thank you all for listening to this presentation. The last few slides include all the references I have used for this project. I want to thank the authors who helped increase my knowledge on the topic and motivated me to work for this project as well. Thank you.